Welcome back. I'm super excited for today's session because we're going to master a topic that is literally an absolute favorite for examiners. I mean, they love this. Today's explainer is all about decoding chronic myeloid leukemia, or CML. Chaliye, let's get our focus dialed in, grab your digital notebooks, and let's dive right into it.
So I want to start you off with a question, just to get you thinking. What exactly makes a single chromosome mutation cause a massive 1 lakh white blood cell count in a patient? एक छोटी सी genetic gadabadi, right? And the bone marrow just goes into complete overdrive. कैसे होता है ये? Well, today we're going to work backward from this massive WBC count to uncover the exact genetic mechanism. ध्यान से सोना, because once you understand this, all the clinical features are going to make perfect sense.
Here's our agenda for today. We'll quickly cover pathophysiology and genetics, then clinical features and phases, key lab investigations, bone marrow findings, management in tyrosine kinase, and finally, treatment monitoring and outcomes, organized and simple.
All right, starting right off with Section 1, Pathophysiology and Genetics. Okay, I need your complete attention here, Becho. We're zooming all the way down to the molecular level, because this is exactly where the whole disease originates. It all starts with a balanced reciprocal translocation between the long arms of chromosome 9 and chromosome 22. This T922 translocation creates what we call the Philadelphia chromosome, and you'll see this in like 95% of cases. Now, what's the actual problem here? Well, when the ABL gene from chromosome 9 moves and fuses with the BCR gene on chromosome 22, the normal myristoyl binding site is lost. Now, why is that so important? Because that myristoyl binding site normally auto-inhibits the ABL kinase. So absent myristoyl binding site, that means the ABL kinase becomes constitutively active. It basically acts as a permanent docking site for ATP, leading to continuous tyrosine phosphorylation. Ye step MCQ में direct आता है, so literally do not forget it. Now, comparing CML to AML reveals a really crucial concept. In CML, the differentiation of myeloblasts is actually fairly normal, and you see this massive proliferation across multiple lineages. The cells actually mature. Now, compare this to AML, or acute myeloid leukemia, where there's a complete arrest of differentiation and just single lineage proliferation. Ratta nahi marna hai, logic samjho. CML cells grow uncontrollably, but they still grow up, whereas AML cells, they just get stuck as immature blasts.
Okay, moving on to Section 2, Clinical Features and Phases.
So we know the genetics now, but what does the patient sitting in front of your clinic actually look like? Let's look at the physical evidence of this mutation. Most patients actually present in the chronic phase. They often walk in with asymptomatic leukocytosis, a WBC count of around 1 lakh. When symptoms do finally appear, you'll see massive splenomegaly. Why? Because the bone marrow is totally packed full, so the body starts making blood in the spleen. That's extramedullary hematopoiesis. Patients will complain of abdominal distension and early satiety. You'll also see fatigue due to anemia, simply because cytokines are suppressing red blood cell production. They might even present with acute gouty arthritis because of massive cell turnover increasing uric acid. And finally, pruritus, or itching. Q, because basophils are elevated and basophils release histamine. See, every single symptom has a totally logical mechanism.
Now, if this is left untreated for about 4 years, CML can actually evolve from this relatively stable chronic phase into a super deadly blast crisis. The absolute most important diagnostic criteria for blast crisis is having blasts greater than or equal to 20% in the blood or marrow. Mark my words, Bachon, this 20% threshold is a guaranteed exam question. You're also going to see bone pain, unexplained fever, and bleeding due to low platelets.
All right, let's hit Section 3, Key Lab Investigations.
This is our detective work phase. What specific tests do we actually run to confirm our diagnosis? Well, on the peripheral smear, you're going to see marked leukocytosis with a left shift, which just means all stages of mature and maturing granulocytes are present. But the hallmark here? That is the myelocyte bulge. You will see maximum myelocytes compared to other intermediate forms. Also, you've got to keep in mind the LAP score, or leukocyte alkaline phosphatase score. In CML, cytochemically, these abnormal WBCs have a very, very low LAP score. This is a classic distinguishing feature, kind of similar to what you see in PNH. Next, we use cytogenetics to confirm our findings visually. On one side, you can see normal cells on a FISH test, and on the other, BCR-ABL positive cells. The FISH test, which stands for fluorescence in situ hybridization, beautifully highlights that T922 translocation. You can literally see the fusion of the genes right there in the interface cells. This right here gives us our definitive proof of the Philadelphia chromosome.
Let's dive into Section 4, Bone Marrow Findings.
The blood tells part of the story, sure, but the bone marrow is the ultimate staging ground and source of this whole leukemia. Let's see what's actually happening inside the bones. If you do a bone marrow aspirate, you're going to see marked hypercellularity. The marrow is just completely packed. Normally, the ratio of myeloid to erythroid cells is around 3:1 or maybe 4:1. But here, the predominant granulopoiesis pushes that ratio to an absolutely insane 30:1. Erythropoiesis is naturally decreased. Now pay close attention to these next 2 points, because these are absolutely crucial buzzwords you must memorize for your clinical vignettes. You will see increased dwarf megakaryocytes and the presence of sea-blue histiocytes, which are also known as pseudo-Gaucher cells. Let's actually look at the marrow pictures. You can clearly see a hypercellular marrow with trilineage hematopoiesis, myeloid hyperplasia, eosinophilia, and dwarf megakaryocytes. And then check out the sea-blue histiocytes. See those large, bluish staining macrophages? They're just full of lipid debris from all the dead leukemic cells. Set this textbook image right into your photographic memory, okay?
Moving right along to Section 5, Management and Tyrosine Kinase.
Now that we've properly diagnosed it, how do we treat it? We shift our focus over to pharmacology. Since we know the exact molecular defect, that constitutively active ABL kinase, we use targeted punishment. Enter tyrosine kinase inhibitors, or TKIs. Let's walk through their unique side effects really quick. First-generation imatinib is famous for causing fluid retention, which classically presents as periorbital edema and muscle cramps. Second-generation nilotinib actually has a black box warning for peripheral vascular disease and can even cause pancreatitis. Then we have dasatinib, which you absolutely must associate with pleural effusion, pericardial effusion, and pulmonary hypertension. Ekdom tian mein rakhna side effects ko. Examiners just love testing this.
Now for an absolute exam pearl. Sometimes the tumor gets smart, and it develops the T315I mutation in the tyrosine kinase domain. This specific mutation makes the CML cells completely resistant to almost all standard TKIs. If you ever see T315I mutation in a question stem, your answer must immediately be ponatinib, given at 45 mg per day, or the newer drug asciminib. Never ever forget this.
Finally, let's wrap up with Section 6, Treatment Monitoring and Outcomes.
Giving the drug is really only half the battle. We have to strictly monitor the patient to ensure these TKIs are actually eliminating the disease burden over time. So we monitor the molecular response quantitatively using DNA PCR to measure the amount of BCR-ABL transcript left in the blood. Look at this strict timeline for log reduction. At 3 months of treatment, the BCR-ABL levels should be less than 10%. By 6 months, it should drop to less than 1%. And the golden milestone, by 1 year, we want a major molecular response, which means BCR-ABL is less than 0.1%. Hitting these specific milestones is literally the most important predictor of long-term survival for your patient.
So we've successfully inhibited the kinase and managed the symptoms beautifully. But here's a rather provocative clinical question to leave you with. Even with a major molecular response, have we completely eliminated the original leukemic stem cell clone from the bone marrow? Or is it just sleeping, waiting for the TKIs to stop? Think about that. It's exactly questions like this that push medical science forward. Keep revising these high-yield facts, keep your concepts crystal clear, and keep learning. I'll see you in the next class.